Hello, everyone.
Hi, Heather.
Hi, Ali. How are you?
How are you?
Good, thanks.
Heather, quick question for you.
Of course.
Are you going to introduce the title of the presentation as well, or no?
I can. There might be a struggle.
That's okay. No, I'm just asking because I want to figure out what I want to say when I start off.
Okay. Would you like to introduce your own slide? You can choose.
Okay, I'll do it then. That's perfect. Perfect.
Okay. I will.
And then I'll make it easier because I don't know if you're going to introduce my name. I'm just going to drop the H part because I can't produce that part. Okay. And I'm just going to keep the Fatehi part, make it easier. I don't know if it's easier that way, but we'll try. We'll find out.
Perfect. I will adjust my notes for you.
I didn't pick that last name. I'm sorry.
All right. I'm positive it's not just the two of us that have working cameras, right?
I don't think so. I think most of us have it.
I don't think so. Yeah. Yeah. How was the morning?
Really good. Really good.
Excellent.
Yeah.
Allie, I see you're not in the basement. They let you loose. Wow, are you lucky?
Once in a while, Danica. Once in a while.
Okay. They like unloosen the chain and you can slip your ankle out and run
Once
up
in
to
a
the
while, I'm
other.
not stuck in the basement doing animal surgeries.
Well, you know.
Or you just turned your camera to make it look like that?
No.
Once in a while, eh? We still have 7 minutes before we're to start. Let's see. Some of our presenters are not here yet. I'm looking for Irene's there. Just a reminder, we are recording these sessions as well. Just keep that in mind.
Heather, hi.
Yes. Hi.
You're running this thing, right?
I sure am.
Oh, thank goodness. So are we gonna run in like these gonna be sequential presentations essentially, right?
Yeah. So we're to start right at the crack of 2 o'clock, and then everybody has their 3 minutes. I will run these sessions the same as a morning one. You have 1 minute thumbs up to let you know that you have 1 minute left, and then your next thumbs up will let you know that your session is over. And there'll be 2 minutes for questions. Preferably, if just for time purposes, if you have a question, just go ahead and raise your digital hand, and the first one up I'll mark, and that'll be the people that we take questions. And if there's further questions, you can direct them in the chat to your speaker for after the fact.
Great.
Yeah.
Perfect. Thank you.
Yeah, and I'll do my best to keep everybody on time.
Are we? I didn't really look very closely. Are we sort of like right to the minute here, or is there some flex time?
Pretty close. So there's about a minute per speaker.
Okay. So don't worry if you like are a tiny bit, like I don't know how Matt feels, but like we have to judge these things, right? So I need time to write some stuff down.
Exactly. So we'll just do our best here. And then at the end of this session, so we are done at 3 o'clock, we'll return back to the main room, the main Zoom room.
Okay, good. Thanks.
Yeah, no worries. Anybody else have any questions? Anybody know Berkeley Scott? And if you could just message him, let him know that he's supposed to be in this room in case he's in another one. See Emily, Allie's here, Diogo's here. Mike Chiu, I don't see Mike Chiu either. And is it Eadric Cai? Anybody know if I'm saying that right? Yes? Okay. Thank you, Allie. Adrian's
He's
here.
one of the cardiology fellows. That's how I know Eadric.
Perfect. Adrian, Elizabeth, and we're missing Ahmed as well. Ahmed Moustafa. We've got about 4 minutes left before we kick off. Ah, there he is. Hi, Berkeley.
Hi, how are you?
Good, thanks. We are just a few minutes out, everybody. And if we miss, for some reason, Ahmed's actually last, so that's okay. He joins us afterwards. Hi, Irene. Thanks for putting your camera on.
Hello. When should I start sharing my screen?
You know what? If you like, I can make you, we'll do that now so that we're set and ready to go at the top of the hour.
Sounds good.
Here you are. Okay.
Can everyone see my screen?
We sure can. Okay, so just a reminder to please stay muted unless you're the speaker until after the speaker is completed for a question and answer period. The question and answer period will be 2 minutes, and I will try and keep us on track as best we can. And I think if everybody, Dr. Rose, Dr. James, are you ready to roll if you want to take advantage of the extra 2 minutes?
Happy to start whenever you are.
Okay. Okay, Irene. So Irene Chung is going to be our first presenter this afternoon. Irene, go ahead, and I've started your time now.
Thank you. Hello, everyone. My name is Irene, and I'll be presenting my project on measuring OMA1 enzyme activity in the dilated cardiomyopathy with ataxia syndrome. DCMA is an understudied mitochondrial disorder prevalent in the Hutterites of southern Alberta. It causes high death rates from cardiomyopathy during early childhood. The syndrome is a homozygous mutation that causes DNA JC19 deficiency, which is associated with mitochondrial fragmentation. Mitochondrial structure is highly regulated by the balance between fission and fusion, and a protein that is involved in this process is OMA1. Which regulates OPA1 by cleaving it at the S1 site. This ultimately induces mitochondrial fragmentation, and which is the imbalance of the two processes with fission predominating. And because DCMA patient cells have high mitochondrial fragmentation and OMA1 is involved in that process, we hypothesize that OMA1 will be upregulated in DCMA patient fibroblasts when compared to controls. And so to address our hypothesis, 3 types of human fibroblasts of varying heart dysfunction severity were cultured. There is the non-Hutterite controls and fibroblasts from DCMA patients with mild or severe cardiac dysfunction. Whole cell lysates were extracted and used in an enzyme assay protocol based off of a study by Tabasic et al. And the assay utilized a fluorogenic reporter substrate, which had a fluorophore and a quencher on either terminals. When OMA1 cleaves this peptide, the fluorophore can start to fluoresce, of which is used to measure enzyme activity. And to further enhance the specificity of this assay, a TPEN treatment was used. And because TPEN is a OMA1 specific inhibitor, the difference in relative fluorescence between the untreated sample and the treated sample with TPEN represents the amount of fluorescence specifically induced by OMA1 protease activity. And finally, Western blotting was used to determine OMA1 protein levels. These bar graphs summarizes the results of the enzyme assay on the left and the Western blotting on the right. Rate of OMA1 activity was calculated as the slope of the difference in relative fluorescence between untreated and TPEN treated over 15 minutes. And significant difference was only found between the control and severe with the severe having a 3.7 times higher OMA1 activity than the control. On the right, OMA1 protein levels was quantified based on band density, normalized against a tubulin loading control. And the control had a 7.1 and 8.9 times greater OMA1 protein levels than mild and severe fibroblasts, respectively. Overall, our hypothesis was partially supported in that fibroblasts from patients with severe cardiac dysfunction had the greatest upregulated OMA1 rate of activity. This is consistent with the increased mitochondrial fragmentation seen in the DCMA fibroblast. And however, the protein levels were less in DCMA fibroblasts relative to the control. So our next steps would just be normalize the Western blot to another protein loading control, and as well to use an alternative cell model such as cardiomyocytes. And I would like to end my presentation by thanking my supervisor, Dr. Greenway, Emily Wachoski-Dark, and Shumei Wang, and of course, the Lipin Institute.
Thank you. So you have 1.5 minutes for questions. If anyone has a question, Dr. Rose, go ahead.
Thanks, Irene. That's a very interesting topic of study. Can you just comment or clarify the Hutterite population that is affected by this, and where you said there's high rates of death, et cetera? What are these patients what are they dying of? Is it consistent with an issue of mitochondrial structure or function? Like what is the main cause of death in these patients? And related to that is, sorry to cut you off, but related to that is your study was conducted in fibroblasts. So do you think this is specific to fibroblasts, or do you think this is more broadly an issue with multiple cell types in the heart?
For sure. So most of the death is caused by cardiomyopathy. The Hutterites are a consanguineous population, so then there is some genetic defects that might have resulted from that. As for your second question, sorry, just to move along quickly here. I think the fibroblast, the reason we said to use cardiomyocytes instead is because it has more mitochondria relative to the fibroblasts, but the reason we used fibroblasts was because it was easier to cell culture and it had a quicker rate of growth. But that is definitely something we can look into doing another cell model.
Thanks. I see you talking, Heather, but you're on mute.
I'm new at Zoom. Thanks, Irene, for the talk, and thank you for your question, Dr. Rose, is what I said. Berkeley, I've made you co-host at this point, so you can go ahead and share your screen. Berkeley Scott is our next presenter.
All right, can everyone hear me?
You sure can, Berkeley. Go ahead, your timer starts now.
Awesome. Hello, everyone. My name is Berkeley Scott, and today I'll be discussing the cardiac consequences of orthostatic hypotension after spinal cord injury. Here we have a 21-year-old male with a cervical spinal cord injury transitioning from supine to upright. Because of his injury, he can no longer regulate his blood pressure. This leads to orthostatic hypotension, which is a drop in systolic blood pressure by at least 20 millimeters of mercury, and sometimes even further to the point of losing consciousness. The clinical reality is that after a spinal cord injury, individuals can experience these episodes on average 11 times per day. Now, could you imagine trying to complete rehab when you start losing consciousness as soon as you're upright? With this in mind, we wanted to evaluate the relationship between orthostatic hypotension and heart disease in the spinal cord injury population. To do this, we combined 3 studies. First, we looked at population-level statistics in individuals with spinal cord injuries to assess the link between orthostatic hypotension and heart disease. Guided by the significant associations we found, we dove into an animal model of spinal cord injury where we induced orthostatic hypotension using lower body negative pressure to see how it affects the heart. And lastly, for a proof of concept, we tested the association between orthostatic hypotension severity and markers of cardiac health in 6 individuals with cervical spinal cord injuries using tilt table testing and cardiac MRI at the Stevenson Center. And for the interest of time, I will only be presenting on the last 2 studies. Based on our animal model, orthostatic hypotension significantly compromised cardiac function. Here, I've included a few measures collected through left ventricular catheterizations. orthostatic hypotension led to reductions in the end-systolic pressure-volume relationship, indicated by a less steep slope in the pressure-volume diagram, and systolic elastance, a load-independent marker of cardiac function, providing insight into cardiac contractility. And lastly, stroke volume, a key measure of cardiac function. Next, we measured the time it took individuals to develop orthostatic hypotension as a measure of its severity. And for some individuals, it was as little as 92 seconds. Looking at a few cardiac measures, we found that cardiac function was reduced in individuals with more severe orthostatic hypotension, with reductions in both left and right stroke volumes. Together, our results highlight how orthostatic hypotension significantly compromises cardiac health after spinal cord injury. With these insights, the next step will be to test if mitigating orthostatic hypotension will preserve cardiac health and improve the quality of life for individuals with spinal cord injuries. Thank you very much.
Perfect, thank you. Did anyone have a question for Berkeley?
Yeah, thanks, Berkeley. I was wondering the compensatory response, is that sustained and or is there a compensation that has a more chronic phenotype in cardiac function?
Do you mean in terms of the animal model when we saw changes in the load-dependent measures?
Yeah, in either of your models, the human or the animal model.
Absolutely. So with orthostatic hypotension in both the animal and the clinical model, we see that chronic orthostatic hypotension is leading to impaired cardiac function that is a more compensatory response to the orthostatic hypotension that is sustained in the chronic phase. And over time, we believe that this chronic alteration in function is also leading to cardiac structural remodeling, which for the interest of time, I wasn't able to also dive into today.
Okay, thank you.
There's still 1 minute left for questions. If anyone has questions for Berkeley.
Maybe I'll just ask a brief one as well. The very interesting work and the changes in stroke volume are very interesting. Given these changes in pressure, there must be heart rate alterations as well. So I'm just wondering if you looked at that and given that cardiac output will be affected by not only stroke volume, but also heart rate. I just wonder if you can comment on that.
Definitely. So in the clinical model, we are seeing that when individuals are going into tilt and experiencing orthostatic challenge, they are experiencing an upregulation in heart rate. And we are also going to be looking into the delta change in heart rate in our rodent model of spinal cord injury and seeing how that is also correlated with cardiac measures.
Thanks.
That was perfectly timed, Berkeley. Thank you for that.
Thank you.
So you go ahead and stop your screen share. And we have Emily. Emily, you should be a co-host at this point and able to share your screen.
All right. Sorry, guys, I don't have a camera. So I hope that isn't an issue.
Can everybody see your screen okay? Perfect. Okay, Emily, your time starts now.
All right, thank you. So I will be presenting my research on characterizing the effect of DNA JC19 deficiency on mitochondrial protein homeostasis. So starting with some background information on dilated cardiomyopathy with ataxia syndrome, kind of repeating what Irene has said. This is the disorder of interest for my project. It's an autosomal recessive mitochondrial disorder resulting from deficiency of DNA JC19. It's clinically characterized by early cardiac dysfunction as well as developmental delay. The largest patient population is the Pathophysiology population of Southern Alberta, and it has a high mortality rate by 1 year of age, while also being extremely understudied and poorly characterized, making it difficult to treat. So as you can see here, this is essentially DNA JC19. It has a DNA J domain as well as a transmembrane domain, and the mutation leads to truncation and loss of the DNA J domain. So looking more at the protein itself, what we know is that it belongs to the class 3 J protein family with its J domain closer to the C-terminal region, and it's suspected to play a role in protein import through association with TIM23 here on the IMM, or through lipid remodeling and association with prohibiting complexes here. However, we're not sure the exact role, which is what my project is seeking to better understand. So I hypothesize that deficiency of DNA JC19 negatively impacts mitochondrial protein homeostasis through abnormal protein import, leading to activation of the mitochondrial UPR, or unfolded protein response. My aims are to characterize protein levels of DNA JC19 and interacting proteins in patient-derived induced pluripotent stem cells that have been differentiated into cardiomyocytes, analyze the mitochondrial proteome using mass spec, assess activation of the unfolded protein response through quantitative real-time PCR, and evaluate mitochondrial protein import. So in terms of preliminary data, I've shown that commercially available DNA JC19 antibodies are insufficient to identify full-length or truncated DNA JC19, as you can see here in control cells as well as patient cells. None of them produce any sufficient bands to detect DNA JC19. And I've also verified our mitochondrial isolates that they produce a mitochondrial fraction as well as a cytosolic fraction, as mitochondrial isolation is used in Western blotting as well as for the mitochondrial protein import assay. And I have also optimized the sample preparation for submitting for mass spec, and I will be submitting those samples later this week, which will be exciting. And that's pretty much all that I have to date in terms of preliminary data, just due to COVID restrictions in shipping and stuff like that. Though I would like to thank my supervisor, my committee members, as well as my lab members for helping me out over the past couple of months, and I'm open to taking questions.
Thank you. Can you explain to me why the commercial antibodies are not picking up the protein here? I didn't understand that part.
So we're not actually entirely sure as to the reason behind why we're not getting sufficient bands for DNA JC19. It is a very understudied protein. So the sequences that I've looked at for these three antibodies here, they target sequences that are fairly close to the C-terminal region rather than the N-terminal region, which would maybe explain why we don't see bands for our patient cells. And it could just be low protein levels in our cells. Honestly, we're not entirely sure, but even for human heart, I loaded 60 micrograms of protein and the bands still aren't, optimal. So we're not too sure the reasoning behind as to why, but.
Thank you.
Great, thanks for the question. Emily has 45 seconds left. If anyone else has a question for her.
For the iPSC-derived cardiomyocytes, are you doing anything to differentiate these towards a specific kind of myocyte? In other words, ventricular, atrial, and also giving considerations to whether the maturity of the cells is going to be an advantage, disadvantage for your study?
Yes, so
25 seconds to answer that.
Okay. So we are differentiating them into ventricular cardiomyocytes using BMS, some sort of, I forget the exact compound, but we are using that, and another lab mate is studying if it's actually ventricular expression or not. Sorry, what was the second part of your question?
Just regarding the maturity of the cells.
Oh, yes. So considering that we're not really looking at metabolism of the cells or anything like that, I'm not entirely sure that maturity of the cells would be a huge issue, since we are looking mostly at protein expression, though obviously it could be an impacting factor. But as of right now, I don't think it's a huge concern for our lab at the moment.
Thanks, Emily. Thanks for your questions. Emily, you can stop sharing your screen for me, and Ali Fatehi, you are up.
Okay. Hi, good afternoon. Can everyone hear me first before Heather starts the stopwatch?
I promise I won't start it until you're ready.
Okay. If everyone can you, so everyone can hear me then. Okay, that's good. Let me just start this. All right. Okay, Heather. Good afternoon, everyone, and thank you. So the title of my presentation today is Liquid Gold, the role of human pericardial fluid cells in cardiac fibrosis. As way of background, as most of you know, cardiac fibrosis is a major cause of heart failure, which affects more than 60 million people worldwide on an annual basis. What happens upon myocardial injury is that you have the normal configuration of cardiac cells that become disfigured and leading to compromised heart function. Various pathways have been implicated and different strategies have been used to different levels of success. What I'd like to draw your attention to is the two areas that our work entails is cardiac fibroblasts, which are cells that are upon exposure to TGF-beta signaling transform from cardiac fibroblasts into myofibroblasts and deposit extracellular matrix byproducts that lead to fibrosis. For those of you who don't know, the pericardium is an enclosed sac that contains the heart and has pericardial fluid. Pericardial fluid is usually straw-colored and has two major components, acellular and cellular. In important recent work, we were able to show in an ischemic rodent model that a specific group of cells called Gata-6 macrophages relocate to the heart and mitigate the fibrotic process. For this project, for the first time, we characterized the human pericardial fluid immune cell population. To do so, we enrolled patients undergoing heart surgery and classified them into either patients who've had a heart attack or without a heart attack. We further subclassified them to different types of ischemic events they've had and the duration lapsed from their heart attack. Using flow cytometry, we found a spectrum of immune cells as shown here. I'd like to specifically draw your attention to this population of cells called the Cd163 macrophages. As you can see, these cells are differentially expressed in the different patient groups. Interestingly, amongst those who've had a heart attack, these cells are replenished across time. This is very interesting and clinically relevant because it mimics what we found in our rodent study. Next, we asked what is the functional effect of these cells in cardiac fibrosis. As mentioned before, cardiac fibroblasts, upon exposure to TGF-beta, transform into myofibroblasts. This is just a confocal image of fibroblasts and a myofibroblast. To assess fibrotic activity, we use a gel contraction assay that upon exposure to TGF-beta, the smaller the gel, the more contracted it is, it denotes more fibrotic activity. What we did is we took cardiac fibroblasts alone and in co-culture with pericardial fluid cells and exposed them to TGF-beta across 72 hours. So the higher the bar, the more contraction, the more fibrotic activity. And as you can see here, in co-culture across 72 hours, cardiac fibroblasts are less active when co-cultured with pericardial fluid cells. This is very exciting and clinically novel, as we may have potentially found a way to find a protective role for human pericardial fluid cells. Next step would be to identify which cells are exerting these protective effects. Thank you.
Great. Thank you, Dr. Fatehi. Anyone have questions?
So do these cells then, Ali, are they actually moving from the pericardial space through the myocardium to exert like transmural fibrosis and those sorts of processes?
That's a great question, Dr. James. So in the human setting, we haven't been able to, for example, tag these cells. We have thought about in preclinical models to be able to tag these specific cells and see if they actually go through. With the Gata-6 macrophages, we were able to show that. With the human pericardial fluid cell, that is one of the future steps that we are trying to do. We're just limited by live imaging and the reagents that we have, but that is something that would be very impactful if we can show that they do indeed go into the myocardium and improve cardiac function.
Thanks.
There's
I
a question.
I have a related question or a follow-up question, which is assuming the cells do, go to the heart, or maybe they don't even need to actually, but what do you think what is your hypothesis in terms of what they're doing? Are they secreting something? Are they interacting physically with myocytes or fibroblasts or other cell types in the heart?
Yeah, thanks, Dr. Rose. That's a great question too. So we've actually looked at, we've done a multiplex analysis of pericardial fluid itself. We found both pro-inflammatory and anti-inflammatory mediators in there. We're trying to figure out what happens when these cells are no longer in their homeostatic environment. So we know for a fact, I didn't present it here, but we know for a fact that the supernatant, the acellular component, has an exact opposite effect. It's actually pro-fibrotic. So I think there is definitely crosstalk between the two. One keeps the other one at bay. To what extent and how that is mediated, we don't know yet. We have found that, for example, in pericardial fluid, there is TGF-beta 1, 2, and 3. we've been able to target the signaling pathway there and attenuate that fibrotic activity. But again, to identify which cells are important, we're planning on doing enrichment experiments to see exactly what's been secreted or what's been produced and what effects that they have in vitro.
Thanks.
Thank you, Ali.
Thank you.
Great questions, everyone. Next, we have Diogo Marques. You should be able to screen share now, Diogo. Perfect. Diogo, can you just do a sound check for me? I don't think I've heard your voice yet.
Yeah, now I think it's working. Can
There,
you hear
I
me?
can hear you now. Yeah, go
Okay.
ahead and screen.
All
Yeah,
right.
there you go. Okay, go ahead.
So hello, everyone. I'm going to start to present my PhD research based on clozapine-induced myocarditis, and I am supervised by Dr. Chad Busman. I would like first to introduce you the PROCLAIM cohort, which stands for Pharmacogenomics of Clozapine-Induced Myocarditis. Basically, we are interested in treatment-resistant schizophrenia patients, and the only drug approved for treat TRS patients is the clozapine, which is very effective. However, it can cause a lot of side effects, and one of them is myocarditis. So the myocarditis after clozapine use, the incidence is around 3%, and the mortality rate is as high as 75%. So we took the blood of the cases and the controls, and we program them into stem cells, and then we differentiate them into cardiomyocytes. So now we have a tissue-specific, patient-specific, and also disease-specific model to study clozapine-induced myocarditis. Additionally to that, we have valproic acid, which is a humor stabilizer that combined with clozapine improves a lot the symptom severity of the schizophrenia. However, the incidence more than double when they are used combined. So this is still a really huge gap in literature, and there are no proposed mechanisms to explain it. So basically what we know is that valproic acid is an HDAC inhibitor, so it keeps the chromatin open. And we hypothesize that clozapine promotes DNA methylation loss, especially in promoters of genes related to inflammation. So probably there is an epigenetic mechanisms of this drug-to-drug interaction. So to start, we start to grow the iPSC cells until they reach the confluency, and then we can actually differentiate them into cardiomyocytes. They are actually beating cells, and they do this contraction. So then we submit those cells to DNA extraction and bisulfite conversion, and finally we submit them to the EPIC array that will investigate around 850,000 methylation sites. Then we had really very interesting preliminary data. Despite we have only 8 samples, we could use the mean of methylation, and we found out that there are different clusters of methylation patterns. So we have one cluster of pluripotent stem cells, one cluster of cardiomyocytes, and one cluster of left ventricle from human heart tissue. But the interesting thing is when we look the heat map, where the green is the unmethylated region and the red is the methylated region, we can see that in yellow here, the left ventricle has a very similar pattern of the methylation in the cardiomyocytes. Also, when we treat it with clozapine, represented here in red, we can see a unique pattern of DNA demethylation when compared to other cells. So we really want to continue with this research by testing the valproic acid on these samples. I would like to thank my lab, the University of Calgary, and the Alberta Innovates that finances me. So thank you so much.
Thank you, Diogo. Any questions? I'll just scroll, sorry, make sure I'm not missing anybody.
Sure, I have a question. I'm just wondering, is there a way this could be used as a screening test in clinical practice for patients on clozapine, picking up the demethylation to, try to identify people who are developing this before the clinical phenotype?
Yes, so basically we're first trying on the cardiomyocyte cells just because we want to first understand the mechanism. But the idea is then to translate to clinical application by just having the blood sample, because it's easier than growing the cells and differentiate them to cardiomyocytes. But we definitely want to kind of establish, because even here, 001 and 008, they are cases and controls. Even when they are cardiomyocytes, then they kind of differentiate themselves from they are different from methylation. So the only thing is that clozapine has to show the same direction in the methylation changes represented by the small circles. So yeah, we definitely want to apply, like do a clinical applicability to that.
Perfect.
Thanks.
That's great. That's the time we have for questions for you, Diogo. Thank you for your presentation.
Thank you.
Mike Chiu, you should be able to share your screen now.
Perfect. Can you guys hear me?
We can, Mike, but you're just in a, I can see all of your slides. You're not in presenter mode if you want to switch that up for a second.
No problem.
There you go. Unless that's what you want us to see.
No, that's okay. All right. So
Hey, Mike, go ahead.
yeah, so we're going to present some of the results from one of our studies I've been doing with Dr. Wilton. It's long-term outcomes of beta blocker use in patients that suffered a myocardial infarction, but have preserved LV function post-revascularization or post-discharge. So in terms of the background on what prompted this study, so routine use of beta blockers is kind of standard care in patients that had a myocardial infarction. We know there's very strong evidence for its benefit in patients that have a systolic dysfunction, if they have heart failure, if they have recurrent ischemia or arrhythmia. However, separately, the use of these medications in patients that have preserved function, or if they, or even further, the duration of beta blocker use is unclear in this population, with kind of varying guideline recommendations from the AHA and the ESC. So our hypothesis was to look for patients with in-hospital post-MI LVEF greater than 50%, follow the beta blocker prescription, and we were hypothesizing that, you know, early discontinuation would not have a decrease in all-cause mortality, recurrent ischemic events. So in terms of our study, we did a retrospective observational study. We combined a few different databases, which include the Approach database, ECHO databases, the Alberta Pharmaceutical Information Network, and the Discharge database. We looked for patients that had NSTEMI or STEMI from 2008 to 2017, and they had a new prescription of beta blockade. We separated them into two categories, one with standard care, which would be new beta blocker prescription that continued to be renewed on the PIN database for greater than 180 days, or early discontinuation, which had beta blocker that was stopped before 180 days. Our primary outcome was the first occurrence of a composite endpoint that combined recurrent acute coronary syndrome, repeat myocardial revascularization, or all-cause mortality. Then next, we looked at secondary outcomes, which were the components of those composite endpoints from 1 to 3, and we used Cox proportional assessments for that. In terms of our results, so from our primary composite outcome, we noted that early discontinuation of beta blockers compared to standard care, which was greater than 180 days, was not associated with any decreased risk in achieving the primary composite outcome, and this was seen from the entire cohort. However, in the secondary outcomes, we did note that there was a recurrence in acute coronary syndrome that was significant in early discontinuation. This was mainly driven by the STEMI population as opposed to the NSTEMI population, and that's what we're just been highlighting in this slide over here, that the STEMI group had a higher hazard ratio for achieving the primary composite endpoint with early discontinuation, and this was driven primarily by recurrent acute coronary syndrome and was not seen for increased mortality or repeat revascularization. So in terms of our findings, we found that in the beta blockers with preserved LV function, early discontinuation was associated with an increased primary outcome in the STEMI population. It was solely driven by repeat acute coronary syndrome, with no differences in repeat revascularization or all-cause mortality. We did not see any differences between early and standard care with the NSTEMI populations. Implication-wise, early discontinuation of beta blockers may be safe in the NSTEMI population compared to the STEMI population, and thus far we think beta blockers should be continued in the STEMI group. But however, further research is needed, more in terms of a randomized controlled trial to help kind of guide beta blocker therapy in preserved LV function, as well as to stratify by ACS type.
Thanks, Mike. You have 45 seconds for questions.
Thanks, Mike. Can you explain why you looked at the 180-day interval for the exposure to beta blockade and whether you explored any other models accounting for different time exposures for beta blockade?
Yeah, that's a great question. So we looked initially at 30 days, 180 days. However, we wanted to have events that weren't related to the primary acute coronary syndrome for admission within the 30 days. If, they had a complication that was non-related, such as a bleed from, a coronary angiogram, a development of an infection and such. So kind of stabilization from the initial event. 180 days, we just chose arbitrarily in terms of close to a year in terms of stability to see at that time point if there was any recurrence. Our total follow-up time was about 56 months in terms of our mean. So we could probably do another repeat analysis at a year to see if there was any differences that pertained out to there. But the thoughts were at about 6 months. Most of the endothelializations and stability of the coronary stent should be present. So we should have a relatively robust analysis to see that they've been stably revascularized.
Great. Thanks so much, Mike. Great question. If you stop screen sharing, now we should have Eadric Cai. Eadric, you should be able to share your screen. Perfect. Do you want to go into the presentation mode?
Hi, can everyone hear me? Or?
We sure can.
Okay, perfect. So yeah, my name is Eadric. I'm one of the cardiology residents. I'm here to present my research working with my supervisor, Dr. Robert Sheldon. So my research topic is the mathematic modeling for determination of cardiac output through arterial blood pressure waveform analysis. In terms of the background, cardiac output is a very fundamental determinant of cardiovascular function. So from a cardiac physiology perspective, it's a very important sort of marker for cardiac health function and also have a good big impact on our clinical practice. And usually measurement of cardiac output in a clinical practice involves very invasive methods such as using a Swan-Ganz catheter, putting a line into the patient's, usually the internal jugular vein to inside the heart chambers and measure the pressures in each of the chamber and calculate the cardiac output indirectly. However, there has been a method that's described from a mathematical model perspective over the past 50 to 60 years using cardiac output estimation through analysis of arterial blood pressure waveform analysis. So on the right side, so this is a typical sort of arterial blood pressure waveform that we can generate from a arterial line. One of the model's concept is to sort of calculate the area under the curve from the beginning of systole to the dichrotic notch, which is the essentially the indication for the beginning of diastole. And calculating the area under the curve will give us the stroke volume, which can further help us determining the cardiac output. So arterial blood pressure waveform can be obtained using the arterial line, which is less invasive compared to Swan-Ganz catheter. And typically we put these lines into the patient's radial artery or sometimes the femoral artery or the brachial artery. But there are advancements in medical technology these days that's enabled us to sort of capture this information non-invasively. So there's a patent that Dr. Sheldon is working on that can essentially give us the similar sort of information but by the patient wearing a device around the earlobe. And I'm just going to try and play this video here. So this is some of the data that we're able to capture in real time of the arterial blood pressure waveform. just through the use of the novel apparatus. So the purpose of my study is to review the literature and compile all the various mathematical models as used to estimate the cardiac output through the waveform analysis, with intent of testing these models' validity by analyzing the waveform obtained non-invasively. So articles published over the past 50 to 60 years describing the use of these models for estimating the cardiac output were reviewed. And essentially a list of equations were extracted from these articles to help us further test the validity in a real clinical settings. So overall, I looked up a total of 13 articles. Each included an equation and the variables required for the calculation of the cardiac output based on the waveform analysis. And I kind of just compiled them into a table here. I think this is very exciting stuff, because testing these models by calculating the cardiac output through these waveform that we obtain non-invasively, it's very exciting that we can allow for capture of real-time sort of cardiac output, even to a beat-by-beat variation, to sort of help us guide our clinical practice if it's feasible. So the next step is to test out all of these equations and find out the best one and compare to a standard of care techniques, such as getting the comparing to a right heart catheterization or cardiac MR. So yeah, happy to answer any questions.
Thank you, Eadric. You have 1 minute for questions. Go ahead, Dr. James.
Thanks a lot for that. Now that you have all these different equations to look at, and
yes,
what is your study going to measure to look at the comparison between the new technique and the gold standard? Are you in terms of bias or reproducibility or validity? How are you going to do this?
Yeah, so I think the next step will be to get a group of patients and then sort of measure their cardiac output through the either cardiac MRI or right heart cath, and at the same time have the patient wearing this apparatus. So then we can get all the different variables and plug them into the equation and see how reliable is, or how close to comparison between the cardiac output that we obtain through calculation compared to like a right heart cath.
Excellent. Thank you very much.
Great, thank you.
Great presentation. I actually have a question as well, but I'll put it in the chat for you
Okay,
later.
sounds good.
Next up is Adrian Chikwanha. I knew I was going to screw it up. I'm sorry, Adrian.
Yeah, that's all right. You were close. Let me put this in presentation mode. Hi, can you all hear me?
We can hear you.
Yeah, so I will be presenting this project I'm working on with Dr. Slonich, and we're looking at, is this time for a change? Are our patients well informed about what ICDs do? So most symptomatic heart failure patients anticipate long survival, and they overestimate the survival benefits of ICDs for primary and secondary prevention of sudden death. So most elderly patients have insufficient knowledge regarding the ethical aspects, function of ICDs, and practical consequences of withdrawing the ICD treatment in the end of life, as most patients would not consider inactivating defibrillation even in the presence of end-stage heart failure or other end-stage disease. So most studies have shown that patients who have sufficient knowledge on ICDs are able to make well-informed decisions at the end of life. Most countries have no unified ICD information for patients prior to implantation that addresses important aspects, including efficacy, complications, deactivation, shocks, and pacing at the end of life with an ICD. So a well-designed national document on ICDs can help our patients be well-informed and make appropriate decisions prior to have their devices implanted and also at the end of life. So our goal is to look at publicly available ICD information packages or bulletins across all Canada that patients get or have access to prior to insertion of an ICD to see if they address all these issues to improve patients' awareness and also knowledge. So, so far we've looked at BC, Alberta, Saskatchewan, Manitoba, Ontario, and Quebec. And Saskatchewan is the only province with no online information available for their patients. And as you can see, all provinces with available information online do not discuss about efficacy of ICDs, and most do not talk about how and when an ICD can be deactivated. And also they do not talk about pacing at the end of life. So our next phase is to look at what's available locally in terms of what patients get in terms of bulletins or pamphlets prior to having their ICD implanted, to see if they address all these issues that I mentioned. So overall, our goal is to come up with a publicly available national document that addresses all these issues to hopefully help improve patients' awareness and knowledge prior to having their ICD implant. And hopefully this would improve our patients' quality of life, especially at the end stage of their disease. So that's our presentation. I'll welcome all the questions.
Perfect timing, Adrian. Thank you for that presentation. Anyone have questions for Adrian about the ICDs?
Adrian, has there been any research, exploring this, I'm thinking qualitative research in particular from the patient perspective in terms of what, patients who've had ICDs and approached end-of-life situations would have liked to know, at the time they had their ICD inserted or made that decision?
Yep. So there have been a number of studies from 2010. I think that was the first one that was published that looked at patients' perspectives at the end of life after their ICD implanted. And they realized that most patients who did not have adequate knowledge in terms of what ICDs do and when and how they can be deactivated, they actually had issues. They actually, like at the end of life, they did not, were reluctant to have their devices deactivated, even at end stage. And most of them overestimate survival or efficacy of ICDs. So that paper concluded that if patients had knowledge in terms of what ICDs do, this could actually improve their quality of life at the end of life, in terms of that patients would actually know when and how their devices can be deactivated. And also this would also help the patient's families going through at the end of life.
Perfect. Thank you, Adrian. You're exactly out of time, so I'll get you to stop sharing. Thank you for the presentation and questions. And we'll move on to our 9th presenter, Elizabeth Chan. You should be a co-host now and able to share your screen.
Yes.
Perfect.
Can you guys see my presentation?
We can, and you can go ahead.
Perfect. All right, so good afternoon, everyone. My name is Elizabeth Chan. I'm one of the cardiology trainees. I'd like to talk to you about my project called Sex-Based Differences in Program Completion and Clinical Outcomes in Patients Who Participate in Cardiac Rehab. My supervisor is Dr. Agarwal. So just a little bit of background. We know studies have shown that survival is improved in patients who participate in cardiac rehab after they've suffered an ACS. And recent studies have shown that women actually have lower mortality when they get to participate in cardiac rehab. Now, the issue is that there remains to be low referral rates and completion rates amongst women compared to men. And so in 2008, the Total Cardiology Program, which is the local provider for cardiac rehab in Calgary, implemented Early Cardiac Access Clinic, which is a special program in order to streamline and improve the referral process for patients who suffered ACS. And since then, the relationship between sex and program completion is has not been studied, and that's the aim of my project. The aim is to determine this relationship, and also secondarily to look at the relationship between program completion and exercise capacity, as well as a composite outcome of 1-year mortality and cardiovascular hospitalization. So this was a retrospective database analysis. Patients were included if they were hospitalized between 2008 and 2016 with an ACS or stable angina, if they had at least one vessel of significant disease found on coronary angiogram, if they were treated with either medicines, PCI, or CABG, and if they were subsequently referred to the cardiac rehab program upon discharge. Again, the primary outcome is cardiac rehab completion, stratified by sex, and the secondary outcomes were exercise capacity, as well as composite outcome of 1-year mortality and cardiovascular hospitalization. So in our study, we had 3,371 patients, of which 726 were females and 2,645 were males. We found that in the baseline characteristics, females tended to be older. There was a significantly higher rate of diabetes, hypertension, COPD, lower risk findings on coronary angiogram, as well as EF of above 50%, so preserved ejection fraction. For our primary outcome, we found that despite all of these patients being referred to cardiac rehab, males still had a higher rate of program completion to females. As you can see, 70% compared to 64%. And this table 1 shows that females were essentially an independent, female sex was an independent predictor of cardiac rehab non-completion, as well as all of these listed here. The only predictor of cardiac completion or cardiac rehab completion was CABG as a revascularization strategy. And just for secondary outcomes, we looked at exercise capacity, comparing completers to non-completers. As can be seen here, completers had a higher initial exercise capacity compared to non-completers. What's interesting is that for completers, despite comparing initial and 12-week, there was still an improvement in exercise capacity, and both sexes showed a similar improvement. And just to wrap up in terms of cardiovascular outcomes, at 1 year, as can be expected, the completers had lower rates of mortality and hospitalization compared to the non-completers. What I want to draw to your attention that's interesting is that amongst the completers, females actually had a higher rate of hospitalization compared to males, which is something of interest that we want to study further. So just to wrap up, despite improved referral rates, there remains a sex discrepancy in cardiac rehab completion, and further study is necessary to figure out and see if we can improve this referral rate, as well as improve the program itself and address the sex discrepancies in the clinical outcomes. Thank you.
Thank you, Elizabeth. Does anyone have any questions? There's 1 minute left for Elizabeth. Oh, you both came off mute at the same time. So let's go with Dr. Rose, you're on top.
Thanks, Elizabeth. This is very interesting. Just wonder if you can comment, if you have any thoughts or insight to, like, so do you think that the major issue then remains rate of referral, or is it completion, especially for females? Like if you increase the rate of referral, but they don't complete, you know, where's the major challenge?
That's a very good question. In my study alone, I did not study the rate of referral since all of these included patients were already referred. What we do know, as I had mentioned in 2008, where this ECAC program was implemented, that was supposed to somewhat address the rate of referral. And we did see a slight improvement. So there was another study done by Dr. Colbert a couple of years ago prior to the implementation of ECAC, and she had studied that rates of referral prior to this implementation were about 30% in women compared to 40% in men. And rates of completion at that time was 60% in men versus 40% in women. So there is a slight improvement since the implementation of this program, but I do believe that you know, there is an improvement in both that are required. I think completion alone, there are certainly steps that we can take in order to improve that, since, you know, this ECAC program was supposed to somewhat streamline the referral. So I think the completion is probably the bigger bit that we can work at.
Thank you.
Thank you, Elizabeth. Thanks, Dr. Rose. And Elizabeth, if you want to stop screen sharing, and Ahmed Moustafa is our last presenter. You should be able to screen share now, Ahmed. And take yourself off mute so we can, perfect, thank you.
Oh, there you go. All right,
Good afternoon, everyone. My name is Ahmed. I'm one of the PGY5 cardiology fellows at the Libin Institute. So I'm going to give you a bit of an insight about my research topic, which is the clinical utility of POCUS in the detection of clinical congestion in stable patients prior to a right heart cath. I'm working alongside Dr. Jonathan Howlett, who is my primary investigator for the study. So just a bit of a background about my research question and the hypothesis is that we all know that cardiac point-of-care ultrasound has been proving efficacy in rapidly diagnosing different cardiac pathology and has been increasingly used in a variety of clinical settings. When you couple it with lung ultrasound, it can actually generate an enhanced snapshot of clinical congestion. And the way that the lung ultrasound does that is by the observation of the B lines, as seen in the diagram on the right, which can be quantified in several lung zones. It can also reflect dynamic changes in the pulmonary water content because the diuretic administration is usually followed by a rapid decrease in the number of B lines, according to several studies that have determined that. In several studies, in people that were hospitalized with acute heart failure, when they guided therapy by POCUS, it actually showed that there was greater decongestion in those patients on discharge, and it resulted in shorter hospital stays without any adverse events. And other studies have actually showed that patients that were discharged from the hospital after a heart failure admission with a total B lines of 15 or more, they actually had worse outcomes compared to the other patients in terms of rehospitalization rates or mortality. But as we stand right now, right heart cath is the gold standard for diagnosing elevated cardiac filling pressures. But however, it's invasive, it's inconvenient, and sometimes it's also associated with risk of complications as any other invasive procedure. So non-invasive techniques with non-inferior outcomes when compared to right heart cath are actually needed for the non-invasive management of these patients. And hence, this is my study question, which is aiming to compare the clinical utilization of cardiac POCUS, coupling it with a lung ultrasound against physical exam and comparing it to right heart cath as well in the clinical decision-making in patients presenting with dyspnea that are actually scheduled for a right heart cath. So the study has not been conducted yet, but it's in the realms of having so. But our methods is we are going to be recruiting 100 patients consecutively that are above the age of 18. They'll actually have a clinically indicated right heart cath for a variety of reasons, whether it's dyspnea, NYD, heart disease, pre-op assessments, cardiomyopathy, suspected pulmonary hypertension. We're going to be doing a cardiac POCUS and a lung ultrasounds that will be performed together with a focused history and a physical exam within 1 hour of their scheduled right heart cath. The results of the ultrasound will initially be blinded from the interventionalist or the clinician doing the right heart cath on that patient. And then we're going to be calculating something called the B-line score, which is the total number of B lines in 6 lung zones, as depicted on the picture here on the right. Several hemodynamic parameters will actually be estimated according to the B-line score. That includes right atrial pressure, mean pulmonary arterial pressure, pulmonary systolic pressure, and wedge capillary pressure. And just to note that there's actually no real cutoffs for those parameters in the literature. So we're going to be adapting our own cutoffs and extrapolating some data from the literature as well. So our outcomes, or what we're aiming to test from the study, is assessing the discrepancy between POCUS, physical exam, and right heart hemodynamic parameters, as well as assessing if there's going to be any clinically significant change in management based on the POCUS results when the results of that ultrasound is actually unblinded to the interventionalist later on, after they've done decision based on the right heart cath. So we are starting the recruitment process hopefully soon. So I don't have preliminary results yet, but hopefully we'll have them soon.
Great. Thank you very much for the presentation, Ahmed. Does anyone have any questions?
That's very interesting. I just wondered sort of what do you think the implication would be about the population that you end up understanding this in when you focus on the group being referred for right heart catheterization? Do you think that'll affect the generalizability in any way?
Not in that sense, because we're only using a specific population. Yes, we're expanding our patient selection, but we're not using it in patients, for example, with acute cardiogenic shock that are admitted to the CCU, etc. So we're going to be using it on a specific population of patients, the NYD dyspnea, the suspected pulmonary hypertension, pre-op assessment, or cardiomyopathy of unknown etiology. And then depending on what we find, again, I don't think we can we cannot generalize the results of our study to all the populations that have been presented for a right heart cath or actually have an indication for a right heart cath. I think it's only going to be specific to those populations. So stable heart failure patients, whether they're being treated as an outpatient or inpatients, but not acute or sick patients. Those I think we can generalize amongst those. Rather than having a right heart cath, they can actually have a POCUS in the clinic, for example. That will definitely help with that.
Perfect. Thank you, Ahmed.
Okay.
Well, you were the last speaker, so thank you so much, everybody. That was wonderful. All of the presentations were excellent. I will actually reach out to some of you personally, if that's okay. I have some questions about your research from a Lebanon Cardiovascular Institute side of things and engagement. Yeah, so please go ahead and take your break now if you need a bio or tech break, and join us back in the main room at 3:05, please.
Thank you.
Excellent talks, everyone. Thank you.